Please check out the description below for a list of topics I will discuss in this module. Welcome to our 8th module on USMLE Biostatistics, where we will discuss clinical decision-making, interpretation, and evidence-based data use. When it comes to evidence-based clinical decision-making, the United States Preventive Services Task Force, or USPSTF, have several levels for assessing the strength of evidence based on medical literature. The higher the level, the stronger the evidence. So here we have level 1, where evidence is obtained from at least one randomized controlled trial. Level 2.1 is where evidence is obtained from several well-designed controlled trials without randomization. Level 2.2, the evidence is coming from several well-designed cohort or case control studies. Level 2.3, where the evidence is coming from several time series experiments with or without intervention. Time series studies are studies looking into trends. And finally, level 3, where we have expert opinion based on descriptive studies. And remember that descriptive studies cannot be used to establish causality. Based on the quality of the available evidence, the USPSTF also have various categories for clinical recommendations. Level A indicates good scientific evidence and the benefits outweigh the risks, and the clinicians should discuss or offer these to patients. Level B indicate fair scientific evidence, but the benefits still outweigh the risks, and the clinicians should discuss or offer these to patients as well. Level C indicate fair scientific evidence, but the benefits may outweigh the risks, and the clinicians should weigh individual patient considerations prior to offering them to patients. Level D indicates fair scientific evidence, but the risks outweigh the benefits, and this is very important to know. And clinicians should not offer these to asymptomatic patients. Level I indicate the scientific evidence is either lacking or of poor quality. Evidence-based medicine refers to integrating individual clinical expertise with the best scientific evidence. However, individual patient factors such as their beliefs, values, and risk profile must be taken into account and respected in most cases despite evidence-based medicine guidelines. Some notable exceptions include communicable diseases, child and elder abuse, where clinicians have a duty to report. Now, the evidence and recommendations from evidence-based medicines are usually judged by the USPSTF guidelines and recommendations as discussed in the previous slides. To synthesize clinical concepts from real data, we need to first come up with answerable clinical questions where the PICO model is utilized. PICO stands for Patient, Intervention, Comparison, and Outcome. PICO models help us to come up with good, informative, and focused clinical questions. Here's an example of a clinical question that is too broad. Does magnesium sulfate work for eclampsia? Using the PICO model, we can rework the question and ask, among pregnant patients in the 3rd trimester with symptoms of eclampsia, is magnesium sulfate more effective than other antiepileptics in the prevention of eclamptic seizures? Here, the patient population are pregnant patients in the 3rd trimester with symptoms of eclampsia. The intervention is magnesium sulfate, the comparison is other antiepileptic drugs, and the outcome is the prevention of eclamptic seizures. After we have formulated our clinical question, we systematically retrieve the best evidence from literature. We then critically appraise the literature for internal validity, bias, precision, clinical importance, and finally, external validity. We then apply the results to our clinical practice and continually evaluate the performance of the new model. With the previous described method, there are a few important limitations to keep in mind. Patient values are not commonly emphasized. Oftentimes, there can be a large lag between the study conductance, result publications, and the application of recommendations. Clinicians' cognitive biases, anecdotal or experience, may cause them to reject evidence-based medicine. Two prominent examples of this include the practice of defensive medicine, which describes the practice of overprescribing tests, drugs, and procedures in order to reduce the threat of lawsuits. And secondly, overtreatment by clinicians because of experience with the rare and shocking patient outcomes or patients' emotional needs. Welcome to our 9th module on USMLE Biostatistics, where we will discuss research ethics. In the first section, we'll talk about informed consent for research. There are a few important principles to keep in mind. First, the patient was provided with sufficient information regarding the diagnosis, options, benefits, and risks of the treatment options. Second, the patient must have decision-making capacity. That is, the patient is not suffering from any altered mental status or any acute psychiatric conditions like acute mania or psychosis. And lastly, the patient is making the decision voluntarily. That is, there is no coercion involved. There are a few required disclosures that need to be made to the patient. First, the purpose of the study and all aspects of the study's protocols and design, any potential risks and or benefits to the patient from the study, alternative treatment options, and potential conflicts of interest, financial disclosures, and study sponsorship. Patients must be provided with informed consent prior to participating in the study, and patients have the right to withdraw from the study at any time and are not obligated to provide reasons for withdrawing. When it comes to research on vulnerable populations, a few more ethical and regulatory principles come into play. First, vulnerable population is described as pregnant individuals, fetuses, children, that is, individuals under the age of 18 years of age, and prisoners. Research on vulnerable populations is regulated by the Office for Human Research Protection, or OHRP. When it comes to research on pregnant individuals, preclinical studies in animals and clinical studies in non-pregnant individuals must have already been conducted, and we need to have data regarding potential harm to the pregnant mothers and fetuses available. Research on children must provide direct benefit to children, and it is not more harmful to children compared to adults. A contemporary example of this is the current research on the COVID-19 vaccine on children. Very important to know is that research on children require informed consent from the parents or legal guardians and assent from children. Remember, unless children are emancipated, children cannot provide informed consent. An assent refers to an agreement to participate, and if children provide no assent, then they should not participate in the research. When it comes to prisoners, the research should investigate health issues that are directly benefiting the prisoners, and the risks to the prisoners cannot be greater compared to the general public, and prisoners cannot be coerced into participation with benefits such as sentence mitigation as compensation. The Health Insurance Portability and Accountability Act of 1996, commonly known as HIPAA, identifies protected health information and sets standards for disclosure. HIPAA dictates that only the minimum necessary information should be disclosed. Very important to know is that HIPAA sets certain exceptions and no consent is necessary for disclosure for the following scenarios. First, to other healthcare providers directly involved in the patient care, such as consulting services, to payment processing agencies, such as the patient's insurance company, for other healthcare operations, such as legal services or auditing services, and lastly, where there is a special public health interest, such as a healthcare provider's duty to report transmissible diseases to the public health department, a healthcare provider's duty to prevent threat of harm to the patient and or others, as well as in cases of elder or child abuse. The Institutional Review Board, or IRB, reviews and approves studies involving human subjects in the United States. They are responsible for ensuring rights and welfare of research participants. The IRB group consists of at least one scientist and one non-scientist. IRB applies research ethics by reviewing research methods where they may approve, deny, or ask for modifications to the study design, to ensure that adequate consent has been obtained, and to ensure that studies are following current institutional, ethical, and regulatory guidelines. Interment analysis refers to analysis of data prior to the completion of the study. Some reasons for stopping a clinical trial prior to their completion using interment analysis include showing that the intervention was clearly beneficial or clearly harmful or clearly futile, and continuing the study will not lead to clinically meaningful effects. For example, the MADITU trial was studying the effects of implantable cardiac defibrillators, or ICDs, versus antiarrhythmic drugs in patients with prior ventricular arrhythmias, and this trial was stopped early when ICD arm showed clear significant benefit compared to the antiarrhythmic arm. That is, 31% reduction in all-cause mortality in the ICD arm compared to the antiarrhythmic arm. And this study can be found in this New England Journal article. Safety monitoring refers to monitoring of adverse events immediately after occurrence by an independent physician with relevant expertise. The independent safety officer is a clinician or a researcher who is independent of the study team, and they are responsible for carrying out monitoring for patient safety, adverse events, trial progress, and data quality. Drug development refers to the process of bringing a new drug to the market once a biologically active drug with likely therapeutic usefulness has been identified. There are 4 phases in drug approval in the United States. These 4 phases were previously discussed on my module on clinical trials. But for review, Phase 1 refers to evaluating the drug for safety. That includes evaluating for toxicity, maximal tolerated dose, pharmacokinetics, and pharmacodynamics. The participants are usually a small number that is less than 50 of healthy subjects. In Phase 2, the goal is to further evaluate for drug safety. In this case, researchers look into optimal dosing, efficacy, and adverse effects. The participants are usually a small number that is less than 100 of patients with a disease of interest. In Phase 3, investigators further evaluate drug safety and this time efficacy for marketing. Here, the goal is to compare the drug to the current standard of care if available or placebo. Most Phase 3 studies are randomized, blinded, and controlled trials with a large number that is greater than 100 of patients with a disease of interest. FDA approval for general use is granted after this stage. Phase 4 studies happen after FDA approval and are post-marketing surveillance studies where we look into rare and long-term side effects of the drugs. When existing treatment with demonstrated efficacy exists, a placebo-controlled trial for a new drug or intervention is considered unethical. This is because we will be subjecting the participants in the control arm to unnecessary harm. In such cases, the new intervention or treatment is compared to the current treatment regimen, for example, through non-inferiority trials or even superiority trials. Randomized controlled trials may not be appropriate when interventions to prevent rare diseases such as sudden infant death syndrome or SIDS or uncommon adverse effects of drugs may require very large sample sizes for adequate power. These are often better assessed by observational studies such as a case control study. A second scenario where a randomized controlled trial may not be appropriate is when the new intervention is clearly beneficial and the control subjects with either placebo or the standard regimen will clearly have poor outcomes. Scheduling refers to federal policies and regulations determining the manufacture, import, use, possession, and distribution of controlled substances. The FDA and the DEA determine the addition and removal of drugs from schedules. A Schedule 1 drug has high abuse potential and no acceptable medical use. An example of this is heroin. A Schedule 2 drug also has high abuse potential but has restricted medical use. An example of this is morphine. A Schedule 3 drug has moderate abuse potential and medical use is permitted. An example of these are ketamine and anabolic steroids. Lastly, Schedule 4 drugs have the lowest abuse for potential and their medical use is also permitted. 2 examples of these include benzodiazepines and tramadol. In this last slide of this module, we will discuss off-label use. Off-label use refers to using a prescription or an over-the-counter drug in an FDA-unapproved clinical indication or an FDA-unapproved age group, dosage, or route of administration. Off-label use is generally legal unless it grossly violates ethical guidelines or safety regulations. You have reached the end of this module and this video series. Thank you so much for bearing with me throughout this journey. Stay well and see you in my next video.